Hi, this is Nursing It, and you're watching an introduction to pediatric nursing. The role of the pediatric nurse is very similar to the role of the adult med-surg nurse, with particular focus given to safety, including age-appropriate safety precautions and restraints as needed to protect therapeutic devices and surgical sites, just like we would for the adult. The plan of care is adopted to be appropriate for the age, developmental stage, and consider regression of the child. Admission can be stressful for the entire family. The parent and caregiver needs are included in the plan of care, and the parent themselves is also included in the teaching and the discharge. There's a wide range of ages that's covered in pediatric nursing. Regardless of the age, the main causes of stress for pediatric patients who are hospitalized includes the fear of pain, separation from their support system, whether that's family or peers, and fear of bodily intrusion. The nurse can help the child alleviate these fears by always being honest, soothing, praising, or reassuring the child after painful procedures, including the parents as much as possible, and that depends on how much they desire or if it's appropriate to be included in particular procedures, and encouraging children to express their fears and providing simple explanations. Maslow's hierarchy of needs really was written for the adult, but can be applied to children as well, thinking about just bringing it down to a child's level. The infant needs their physiologic needs met. The toddler starts to think about safety and separation anxiety. The preschooler starts to think about establishing, those relationships. The school-age child is developing, their self-esteem and some independence. And then the teenager's thinking more about kind of, who they are, what they want to be, and what they want to achieve. So in the infant, their major goal, according to Erickson, is to learn to trust or develop trusting relationships, or if they fail, they'll develop a sense of mistrust. The infant ranges in age from a newborn to 1 year of age. At this point in time, the focus really is on their physiologic needs: food, warmth, shelter, diapering, elimination, being cuddled and loved. If those physiologic needs aren't met, they are going to lose trust in their caregivers. So being separated is very difficult for them. Their parents are their primary source of support, and it's important to include the parents in the teaching and in procedures as much as they feel comfortable. For safety concerns at this age, SIDS becomes an issue, so we use the Back to Sleep program for teaching. Things like choking, toys, small pieces, items around the house should also be evaluated. Falls are a major concern, even for the child who's not old enough to roll over, and car seats should be checked by a car seat specialist to be sure that they're appropriate for the age and the weight of the child and installed properly in the car. In the hospital, cribs should be kept with the sides up and locked, and safety belts should be used in high chairs. No children of any age should ever be left alone near water or on high surfaces because of the risk of falls, drowning, and injury. According to Erickson, the toddler struggles then with determining their own autonomy versus feeling shamed, being told no very often. Their focus is really on exploring the world around them, but while keeping their caregivers close. They alternate between dependence and independence, and this can be a very confusing time for them. Their parents are really the center of their world, and they increase their sense of security through the rituals and routines that they have at home. So loss of these home routines can become a source of increased stress for the hospitalized toddler. As they're learning to participate in self-care, toileting, dressing, bathing, they're also exploring the world around them, and safety becomes a key concern at this age because they're still exploring the world largely with their mouth. Injuries and accidents are the leading cause of death in this age group. Things like traffic, burns, falls, choking, poisoning, drowning, electric shock, and animal bites are all major causes of injury. Stranger danger becomes a real thing, and separation anxiety can become a struggle for the nurse caring for the toddler who may protest very loudly, even hit, kick, or bite when separated from the parents or approached by a provider. The nurse also has to be alert for ineffective coping mechanisms of separation. From protest, they go to despair, which looks like, depression, and then detachment or denial, which can lead to permanent trust issues. So be alert for those and try to intervene early on. The preschool age child has the initiative versus guilt kind of thing going on. So they are trying to learn and establish kind of power and control through effective play, initially like parallel play and then play with peers. They have this wonderful, magical, fantastical thinking where, they have playmates that don't exist and inanimate objects are alive and have feelings and names. And even though they're so creative, they have very concrete thinking in terms of what things mean. So they're very concrete and literal in their translation. The focus becomes a little bit less on the parents, and the challenge becomes then to really explore what it is that they are worried about or what they're thinking, and to help them overcome the guilt that they may experience over their illness or injury. And a lot of times we can do this through play. Scheduling time for them to play is very therapeutic, and just really exploring their feelings. Safety is still a huge concern at this age. Traffic is an issue. They may run out into traffic, teaching them about traffic safety, especially if they're riding, a bike or a three-wheeler. Burns are an issue, especially pulling hot things off of stoves. Poisoning, more from mimicking things that adults do, so like alcohol and drug ingestion becomes more of an issue because they saw somebody else using it. And then we start to teach them about strangers in terms of not accepting rides, not going with strangers, and not accepting candy or food from strangers. In the hospital, the safety remains the same. They can't be left alone on elevated surfaces or in water. We want to make sure that medications aren't left anywhere where they can reach them, and just the general rules of safety still apply. For the school-age child, they're tackling this industry versus inferiority. Can they be successful and productive in school with their peers? Can they learn? Can they create things? Can they synthesize new information? Or are their peers passing them by, and do they feel inferior? The peers now are becoming the main focus of attention, not the parents, and they worry about being separated more from their peers and from their schoolwork, leading to this inferiority that people are doing things that they're getting left out of. The challenge for the nurse is to bring school to them, so making sure that they get their work, that they have tutors, or allowing them to contact their peers, whether it's face-to-face or electronically, like FaceTime or Skype or whatever. Safety is still a huge concern. At home, we want to make sure that they're wearing the appropriate helmets and pads, that they're not getting into cars with strangers, or not interacting inappropriately online with people that they shouldn't be. We also at this age start to teach them about fire safety, first aid, and even babysitting classes as they start to take a more active role in safety and safety prevention, or illness and injury prevention. The adolescent is trying to develop their own identity versus kind of an identity confusion. And these are 13 to 18-year-olds that are really focusing on who they are, fitting in with their peers, and separating from their family. Their peers really now are the primary focus of their life. And for us, the challenge really is that they oftentimes will resist adhering to the plan of care out of fear of being different or loss of control. Patients in this age range that have a chronic disease oftentimes will not take their medications, or when they're hospitalized, they will, kind of rebel against the system. So they'll try to not take their medication, or they won't write down their intake and output, or, they'll pull out their IV or whatever it is, just to be difficult because that helps them feel like they're more in control. So having an open, honest line of communication is super helpful with this age range because it allows you to really understand what it is that they're struggling with. Safety for the adolescent includes sports, activities, drugs, alcohol, driving, and sex. So while we do sex education with the school age group, usually we don't see willing participant sexual activity until about the adolescent years. So sexually transmitted infections become more of an issue. Some things that are important to teach the adolescent, and again, when the parents are not in the room is probably the most appropriate time to have these conversations, unless they're very open with the parents. But unlike other viral infections that you can catch, or when you have a vaccine, when you contract a sexually transmitted infection, you don't develop an immunity to it afterwards, so you can continue to get it over and over again. Barrier device use helps decrease the spread of things like HIV, HPV, syphilis, and HSV, but it does not completely protect against it, especially things like HPV, syphilis, and HSV that tend to be on the entire peri area versus HIV that is just direct blood and bodily fluid contact. HPV, or the human papillomavirus, is the virus that causes both external warts and then internally cancer. And it causes anal and rectal cancers, it causes oral cancers, and it causes cervical cancers. On the skin, the external low-risk versions of this cause these kind of cauliflower-looking growths that are oftentimes flesh-colored or even a little bit pale. And then internally, we catch cervical mucosal changes with pap smears. Syphilis causes these painless cankers on the outside, but if that does occur, then we need to catch it and treat it very early because it can become systemic and it can cause all sorts of neurological problems. And syphilis, interestingly, is on the rise again. So the herpes simplex virus, there's HSV1 and HSV2. 1 used to be considered oral and 2 used to be considered genital. There's so much crossover now between the two of them. You can't really differentiate between where they are on the body and what type that you have. But the important thing to know is that it's always contagious. It's not just contagious when the lesions are present. It's not just contagious right before or after. It's technically always contagious. The virus always exists on the person. So, they need to take the full course of antibiotics to treat a bacterial infection like gonorrhea or chlamydia. If they have trichomonas, they need to take Flagyl, and then they need to take their antivirals for things like HSV, but they are still technically contagious, and so using barrier devices, things like that, is really super important. And then, of course, the pregnancy issue and contraception is also really critical in this age range when you're having a conversation with a adolescent who is either sexually active or considering being sexually active. So those were the age ranges. Let's just talk a little bit about the nursing assessment then of all of these patients. So again, there's going to be a wide range of normal. The thing that's the most helpful probably is having a chart rather than trying to memorize. There are different formulas out there that we use to estimate normal blood pressures or vital signs for kids, but just in general, when you're born, your pulse and your respirations are much higher than an adult, and over time they become lower and become the same as an adult. Your blood pressure starts out much lower than an adult and over time raises and becomes higher. And then pain, just like with an adult, has both subjective and objective findings, and it's important that the nurse recognizes both of those. So as far as temperatures are concerned with kids, rectal temperatures are the most accurate, but not taken routinely because they can cause trauma to the anal and rectal mucosa, and if the child is immunocompromised, that can cause an abscess and sepsis. Axillary temperatures are taught to parents at home, aren't the most accurate, but typically we use those on infants that are afebrile. The tympanic temperature is the closest to core temperature because the tympanic membrane shares circulation with the hypothalamus in the brain, but you have to use the correct technique when taking the temperature. The apical pulse should be auscultated until age 5, and then radial can be used. Respirations are most accurate if obtained while the child is at rest, not crying or screaming. And blood pressure is normally lower in children than adults, as I said, but make sure you're using the correct size cuff. And that's probably the reason why we get erroneous readings most often. It's not patient movement, but cuff size. Pain should be assessed in children as it is in adults using both subjective and objective findings to determine the presence of pain. Children often underreport, so use your nursing observations and judgment to assess their behaviors, not just reports of pain. Height, weight, and head circumference are measured routinely during office visits to track growth on the pediatric charts. Weight should be naked in infants or undressed in older children, just like they are as adults once they can stand on the scale. Head circumference is measured on all children until 3 years of age and older if they have neurological problems such as head injuries, tumors that increase intracranial pressure, or hydrocephalus. Medication administration also can pose some challenges in the pediatric patient. In general, treatments like IV starts are done in the treatment room, never in the playroom, and preferably not in the child's room to avoid associating the room with painful procedures and to not disturb other children. Routine medication administration, though, like the oral route, is preferred and can be done in the patient's room. So when possible, use the oral route. Do not dilute the medication, but rather use an oral syringe or a dropper to administer it buccally, and then follow it with something that tastes good for the smaller child. And once the child can swallow pills, then just observe them swallowing the medication, obviously, to make sure that they're safe and that they don't choke. Rectal medication, such as an enema or suppository, should never be hypotonic like tap water, because it can cause massive fluid shifts if it's absorbed through the intestinal wall, and which would then overload the vascular system and cause fluid volume overload. So instead, they get saline enemas. Eye drops are potentially difficult on a child. The technique is really the same though as an adult. Pull the lower eyelid down and place the medication in the conjunctival sac. Ear drops are adjusted based on age. So under 3, pull down and back, and over 3, pull up and back, just like you do to use the otoscope or a thermometer. Nasal sprays and drops are the same. Just make sure you don't use anything that's oil-based because of the risk of aspiration, and be really gentle because the nasal mucosa is highly vascular and can bleed if you damage it. Suction if needed to clear the mucus out of the nose. And when we're teaching parents, typically we recommend just the little blue bulb syringe. There are a lot of others though that are on the market that they can buy at a drugstore. Metered dose inhalers and nebulizers have spacers and masks that are specific to the correct size and age of the patient to facilitate medication administration more effectively. Specifically, let's talk about IV therapy for just a minute. The role of the nurse during IV therapy is to check the site hourly for the correct rate and the patient response to therapy and the volume in the bag. So if I'm giving the patient a medication for pain, I want to check their pain. If I'm just giving them IV fluids, then I want to check their hydration status. A good rule of thumb is to set the pump for 1-hour intervals. So just set it for a 1-hour volume, and that will prompt you to return to check the pump every hour. Always assess the site for signs of infiltration, cool, pale, puffy, painful, or signs of phlebitis, red, warm, firm, streaking, and painful. And stop the infusion if you notice that and notify the correct person. Fluid volume overload can occur very quickly, especially in younger pediatric patients. So monitor for those signs. Puffy eyes would be first, then tachycardia. Things like hypertension and JVD tend to be late findings in kids. Use an arm-borne restraint to protect the site and cover it to prevent tampering. If you're using a gravity-fed IV set, only use a 60 drop per milliliter set for infants and small children to prevent accidental fluid volume overload. And maintain a very accurate intake and output. So weigh diapers for infants, subtracting the weight of the dry diaper from the weight of the diaper with the urine in it, and 1 gram equals 1 milliliter of urine output. You'll notice here in this picture that these are little guard devices that stabilize the extremity, and then they also have a little cap that goes over the IV site to keep the child from picking at it, bumping it, or playing with it. It is possible sometimes that adults or visitors will also attempt to tamper with IV sites, so protecting them is pretty important. So to summarize, pediatric nursing care, there's a wide range of normal, and you need to really think about what's normal for your patient and adjust care to meet the needs of the patient and the family. Consider the age, the developmental stage, and regression. Promote and restore independence and functioning the best that you can for the patient's baseline. And consider the specific safety needs of each individual. We want to teach repetitive over and over again, firmly but gently, and make sure that everybody has the best experience possible so that if they need to come back again, that they have a good memory of their last visit. Thank you so much for watching. I hope you enjoyed this presentation.